Good evening to all the viewers who are watching live and will be watching on a recorded version. So today with a brand new topic, and those who are from the beginning have noticed that we were unable to provide you with some details in our Telegram channel. So pardon us, we are facing some issues and we will manage to get it back. So without wasting any more time, let's just jump into this interesting topic after the 30 seconds countdown time.
Good evening, everybody. Good evening, sir.
Good evening.
And Happy New
Good
Year to
evening.
all our viewers across the country and across the globe, all the NHNs and homeopaths and the medicos and the medical professionals across the globe. We, by the blessings of Almighty and all the senior professionals in the field, are now on the 63rd episode of Continued Medical Education Online Live Program. And with your permission, sir, may I call on the inaugurator tonight?
Sure. Please call it.
Thank you, sir.
Call her.
And as we are trying to touch each and every country across the globe, in NIH, we had already from NIH, we had connected Nepal, we had connected, we had connected Canada, US, and also Sri Lanka. Now we are connecting with Bangladesh. Our tonight's inaugurator is 22nd batch UG and ongoing 22nd batch PG from National Institute of Homeopathy, and she is Dr. Devajani Saha. I'll request our backstage editor to bring on screen Dr. Devajani Saha to inaugurate tonight's session. Welcome on screen, Devajani. Orko, Dr. Devajani.
Maybe some network problem.
Yeah, might be. Sir, by the time you go on with the appeal, I think Orko will bring her on screen immediately.
Okay. Good evening and warm welcome to the first CME of this year, 2023, and the 63rd CME of Alumni Association Online. So it's a great privilege for all of us that we got a platform where we can share our experiences. So it is our earnest appeal to all the alumni of the National Institute of Homeopathy to come forward to contribute their experiences, share their experience, concept, ideas, learnings, whether it is ritual, clinical, research, whatever, by which all of us will be encouraged and all of us will be able to improve ourselves gradually. Today's topic is a beautiful topic. We know very well that germinal layer, first germinal layer was endoderm, then mesoderm, then ectoderm. This endodermal layer starts from the oral aperture and ends into the anus. Today's topic is beginning and end of this endodermal layer, GI system. Very, very important, very relevant, and almost all cases we used to see their tongue, and many more cases regarding this anorectal disorders, which is very critical, very disturbing, very painful, at the same time very risky also. Usually conventional treatment of medicine is operation. That is one way hazardous. Second is there is chances of incontinence of anal muscles sphincter. So anyway, homeopathy all along is dealing with these anorectal disorders very confidently, and homeopathy has gained name regarding these anorectal disorders. We will get many experiences, many information from our brilliant speaker of the day, Dr. Uh, our Ujjal Mandal, Superintendent of National Superintendent of National Institute of Homeopathy,
Sir, Devjani
and
is now on screen.
Devjani has come. So let us start. Bidyut, please.
Am I audible, sir? Hello. Am I audible?
Yeah, you are audible. You are audible, Devjani.
Okay, sir. Thank you, sir. Good evening. Namaskar. Happy New Year. To introduce myself, I am Dr. Devajani Saha from the neighboring country, Bangladesh. And I believe that in respect of homeopathy, there been a long time exchange of views between India and Bangladesh. I have completed my BHMS from National Institute of Homeopathy, Kolkata in the year of 2016. And at present time, I am pursuing my master degree course in the same National Institute of Homeopathy, Department of Homeopathic Mathematica, 22nd batch PGT. It's my great honor to inaugurate 62 CME. Today, we'll be talking about anorectal diseases, and this is the subject for discussion, which remains the totally untouched, and we need to explore the scope and limitation of homeopathy in respect of anorectal diseases. In our day-to-day practice, we get a number of patients who are suffering from anal fistula, hemorrhoids, rectal cancer, and to discuss about this, we have with us a right person in a right place on right subject who have a long time experience at National Institute of Homeopathy at the Department of Surgery. I am very proud to announce his name, and he is Dr. Ujjal Mandal. He is the alumni in this institution. While inaugurating this 62 CME, I am once again happy to announce the name of Dr. Bhaskar Bhattacharjee. Dr. Bhattacharjee presently working as a lecturer in Homeopathic Mathematica Department at the Calcutta Homeopathic Medical College and Hospital. He will be talking about the tongue and its clinical importance of homeopathy. In my knowledge, tongue can make certain clues to make disease diagnosis, prognosis, and also gives clue for the selecting remedy. We have with us Dr. Debashis Biswas as moderator. Dr. Biswas is the head of the Department of Gynaecology and Obstetrics in Calcutta Homeopathic Medical College and Hospital. We all will wait for his moderation and views in his subjects to be discussed. I am Dr. Devajani Saha, alumnus of NIH Alumni Association, hereby inaugurate this program. I would like to thank all the viewers who are watching this program and also the viewers who will be watching in future also. And thankful to our President, Dr. Narayan Kalyani, and Secretary, Dr. Bidyut Mukherjee. And I'm also thankful to Dr. Prolay Sharma, Dr. Ompriya Mishra, and Dr. Deep Sharkar. Enjoy the CME. Handing over to moderator Dr. Debashis Biswas for the further continuation. Thank you.
Thank you, Dr. Devjani. First of all, I am thankful. I would like to say that I am thankful to Dr. Kalyani sir and Dr. Bidyut Mukherjee, our beloved Bidyut Da, for inviting me, for selecting me as the inaugurator of the first seminar of this year. Not inaugurator, moderator of the first seminar this year. Today, two clinical topics, two very important clinical topics. One is the tongue, its clinical importance by Dr. Bhaskar Bhattacharya, and second topic, anorectal disease by Dr. Ujjal Mandal is going to they are going to deliver their topic. This seminar conducted under the leadership of Dr. Bidyut Mukherjee is a great thing. This and today I'm not wasting any more time. I am very eagerly waiting from these two clinical topics, one from Dr. Bhaskar and one from Dr. Ujjal Mandal sir. First of all, I would like to invite Dr. Bhaskar Bhattacharya, lecturer, Department of Materia Medica, the Calcutta Homoeopathy Medical College and Hospital, on screen to deliver his lecture.
Thank you, sir. Good evening and a warm welcome to all the viewers. My respect to all my teachers, my seniors, love to my colleagues and juniors. Let me introduce myself. I am Dr. Bhaskar Bhattacharjee, 13 batch UG and 12 batch PG of Department of Homeopathic Materia Medica from our prestigious institute, the National Institute of Homeopathy. Previously, I was posted as Homeopathic Medical Officer. Now, I am as a lecturer in our Heritage Institute, the Calcutta Homeopathic Medical College and Hospital. I really feel honored and privileged to be a part of this Alumni Institute and would also like to thank the Alumni Association for providing me this opportunity, inviting me as a speaker today on 8th January 2023. So a happy new year to all the viewers. Without any further delay, I would like to start. My today's topic is tongue and its clinical importance in homeopathy. So as we all know, tongue, which is the organ for taste perception, an organ for speech, acts as a reflection of our gastrointestinal system. Also, it is having a great significance in large number of systemic disorders. As prior to the major changes that takes place within different system, different organs, there are certain characteristic changes or manifestation takes place in the tongue, which helps in the diagnosis of the disease. So be it a hematological, endocrinological, neurological, respiratory or cardiac disorder, tongue provides a lots of information about the diagnosis of the disease process. We as a homeopathic physician very well know the importance of tongue in our day-to-day practice. As we all know that in our Materia Medica, There are many homeopathic medicines where there are characteristic manifestations are present or given of the tongue, which helps not only in our case taking, but also it helps in study of the case and also ultimately the selection of the simillimum. Now, tongue, as we know, is a muscular organ in our buccal cavity situated in the floor of the mouth. It is considered as an organ for taste, for mastication, swallowing, and speech. Now, let us come to the anatomy portion. Tongue has 5 parts anatomically. It has tip, margin, dorsum or superior surface, inferior surface called body, and the root. Its dorsum surface is divided into anterior 2/3 or the oral part and posterior 1/3 or the pharyngeal part by sulcus terminalis. The anterior 1/3 has a medial groove and lingual papilla are situated on this part. The lingual papilla are further of 4 types: filiform papillae, fungiform papillae, valid papillae, and folia. These papillae are responsible for rough dorsal surface of tongue. This papillae contains taste bud and thus plays important
Sir,
role.
sorry to interrupt. Sir, sorry to
Yes.
interrupt. But your screen has froze, sir. The slides are not changing.
Okay.
Can
Now
you
it is
just
changing?
reshare again? No, sir.
Not changing.
No, sir. Sir, can you just reshare again?
Yes, okay.
But do one thing. Just upload the file and then this is now showing. The next is
Now it
showing.
is changing.
Sir, if it is okay, just not to turn on the slideshow, sir. You can just change like this.
Okay.
It
Okay.
will be best, sir. Mm, thanks.
Okay. Inferiorly, the tongue is connected to the floor of the mouth by frenulum, lateral to which deep lingual veins and opening of the ducts of submandibular glands can be seen. Root of the tongue rests on the floor of the mouth and is attached to the mandible and hyoid bone. The nerve, blood vessels and extrinsic muscles enter and leaves the tongue through this root. The tongue has 4 intrinsic muscles and 4 extrinsic muscles. Blood supply is done by the lingual artery, which is a branch of the external carotid artery. Venous drainage is by the dorsal lingual vein. Lymphatic drainage takes place mainly to the submental, mandibular, and deep cervical lymph nodes. The tongue has both the sensory and the motor supply. Sensory supply to the anterior 2/3 is by the lingual nerve, which is a branch of mandibular division of trigeminal nerve, which carries the general sensation by the chordae tympani, which is a branch of facial nerves which carry the taste sensation. Sensory supply to posterior 1/3 of the tongue is by glossopharyngeal nerve, which carries both general and taste sensation. Motor supply is mainly done by the hypoglossal nerve. Now let us come to the physiology of taste sensation. It is one of the most important function of tongue, that is taste perception. Taste basically helps the person to choose the food item according to his or her desire and metabolic needs. The primary sensation of taste are sour, salty, sweet, and bitter. Literally, there are hundreds of tastes which a human tongue can perceive, and that too of all different combination of primary sensations of taste. Like the sour taste is caused by acid, the intensity is directly proportional to the concentration of H plus ions. In case of salty taste, it is the concentration of sodium ion. Sweet taste, there are many class of chemicals which cause sweet taste, but mainly organic chemicals like sugar, glycol, alcohol, ketones, aldehydes, esters, amino acids, etc. Bitter taste, it is mostly caused by organic compounds, particularly long chain organic substances that contain nitrogen and
Dr.
second
Bhaskar, Dr.
alkaloids.
Bhaskar, I'm interrupting you. Your screen, please do the screen share. Your slides are not visible. Okay. Yeah. Share the screen and make it be,
Now it is visible.
start the slideshow. No, no, it is still not visible. Uh, make it visible and start the slideshow. In PowerPoint presentation, start slideshow, and then you can change from your laptop. First, first of all, to the screen share.
Is it visible right now? Now it is visible.
No. Hello.
Now it is visible.
Yes, visible. Now it is visible.
Okay. Thank you. Now distribution of taste perception. We mainly perceive taste sensation of salt and sweet on our tip, sour over the lateral margin of tongue, and posteriorly the bitter taste. As we can see the image showing the distribution of taste perception in different areas of the tongue. Transmission of taste signals to central nervous system. Now the taste buds, which contains the taste cells, has receptor proteins which receives the taste stimulus, and they are carried by the nerve fibers around the taste cell to the synapse at the tractus solitarius and ultimately to the thalamus. Physiology of speech. The second important function of tongue is articulation of speech in human. Tongue forms the motor part of the speech process, helping in formation of words under the influence of CNS. It's a complex process including coordination of different organs. Like as the sensory input takes place through our eyes, ears. These are interpreted and the thought process formation takes place in the vernix area. This in turn results in the formation of words and the act of vocalization through the Broca's area, which influence larynx, lips, mouth, tongue, respiratory system, and accessory muscles for output of speech. So many organs acts coordinately, resulting in the production of voice. Now the clinical significance of tongue in various systemic disorders. Macroglossia or large tongue. The image is showing a case of macroglossia or large tongue, which we find in cases of acromegaly, mixed edema, cretinism, Down syndrome, primary amyloidosis, hemangioma, lymphangioma, angioneurotic edema, etc. This is a picture showing macroglossia in a case of acromegaly. We can see in the image the enlargement of the acral parts, the hand, fingers, and also over the facial region there is frontal bossing and enlarged nose. This is a case of cretinism over the left side of the screen. On right side we have the tongue representing a case of primary amyloidosis. The imprint of teeth over the tongue can be seen. Next, microglossia or small tongue. The causes are cerebral dysplasia, bulbar palsy, pseudobulbar palsy, motor neuron disease, lower motor neuron disease of 12th cranial nerve, and congenital defects. Dry tongue. The causes are dehydration, mouth bleeding, xerostomia, Sjogren's syndrome. Excessively moist tongue can be seen in post-encephalitic Parkinsonism, heavy metal poisoning like mercury. Pale tongue found in severe anemia. Blue tongue. The causes are central cyanosis, methemoglobinemia, sulfhemoglobinemia, and intake of blue food items. Yellow tongue. The causes are jaundice, intake of yellow food items. Black tongue. We can see in ingestion of bismuth charcoal, also in Addison's disease, and black hairy tongue, which the image is showing, is produced due to the failure of filiform papillae to desquamate normally. Smooth glossy tongue. There is total loss or atrophy of the papillae, resulting in a smooth glossy tongue, seen in cases of iron deficiency anemia, pernicious anemia, tropical sprue, pellagra. Geographical tongue. Here a denuded red patches migrating across the surface of tongue due to rapid loss and regrowth of filiform papillae. Strawberry tongue, seen in scarlet fever due to hypertrophy of fungiform papillae. The tongue looks red with papillae standing out as white dots. Scrotal tongue. Here we can find deep horizontal fissures in the tongue. Median rhomboid glossitis. Here central papillary atrophy of the tongue occurs resulting in a lozenge-shaped denuded area in the middle of the tongue posteriorly. Several predisposing factors like smoking, denture wearing, diabetes mellitus, candida infections can result in this type of tongue. Magenta tongue, a strawberry red tongue, usually due to riboflavin deficiency. Now, ulcers on tongue. First, aphthous ulcer. This is a usually benign ulcer that forms on the mucous membrane, also known as mouth ulcer, aphthous stomatitis, Sutton's disease, and canker sores, caused by emotional stress, mechanical trauma, deficiency of vitamin B, iron, folic acid, etc. Tuberculous ulcers, usually caused secondary to pulmonary infection through infected sputum or by hematogenous spread. Primary infections are rarely seen, and in these cases, we have to rule out tongue cancer. Syphilitic ulcers. Oral chancres can be seen during the first stage of infection. In secondary syphilis, snail track ulcer on the dorsum of the tongue are seen. Behçet disease ulcer. It is a disease of unknown etiology with recurrent oral and genital ulcers, also systemic manifestations, particularly ophthalmological and neurological. The ulcers may mimic aphthous ulcer, but they are recurrent, numerous, large. They have a necrotic floor surrounded by an erythematous halo. Hairy leukoplakia. These are usually painless, corrugated white lesions on the tongue due to Epstein-Barr infection, specially seen in AIDS patients. The lesions are typically furry or hairy. Oral thrush or candidiasis. A candidial infection leading to formation of creamy white, slightly raised or smooth lesions in mouth, which may be painful and may bleed on brushing. Squamous cell carcinoma of tongue has strong association with alcohol consumption, tobacco smoking, and Epstein-Barr virus infection. Now let us see the congenital defects of tongue. Aglossia is a case of absence of tongue. Ankyloglossia, also known as tongue tie, it is a defect of short frenulum due to which the patient is unable to protrude the tongue, as it can be seen over the image. Now, deviation of the tongue. In upper motor neuron lesion of 12th cranial nerve, the tongue is deviated to the opposite side, whereas in lower motor lesion, it is deviated to the same side. Tremors of the tongue, seen in anxiety neurosis, thyrotoxicosis, and chronic alcoholism. Fasciculation of tongue, seen in motor neuron disease and lower motor neuron palsy of the 12 cranial nerves. Dysarthria or difficulty in articulation. It is of 5 type. Spastic dysarthria, that is due to upper motor neuron lesion of 12th cranial nerve. Flaccid dysarthria due to lower motor neuron lesion of 12th cranial nerve. Scanning speech, which seen in cerebral disorders. Monotonous speech seen in Parkinsonism stammering speech, congenital or due to developmental disorder. Now let me put some light on our organ of medicine, what our master Hahnemann had mentioned regarding tongue before we enter to the materia medica part. Naturally, our taste perception should be normal and all kinds of food, drinks, we should taste the way they should be. But miasm causes a perversion in our entire system, in every aspect of our life, so also in our taste perception, which comes from perverted nerve impulses. But we as a homeopathic physician are more concerned with the miasmatic symptoms which are important during our case taking and thus in the selection of the medicine. So taste and homeopathic overview: sour, bitter, sweet and burnt taste, it falls under the soric miasm or soric taste. Bitter taste with yellow coated tongue is a strong feature of Sora. Putrid, musty or moldy, fishy taste, it falls under psychotic miasm. Metallic taste under syphilitic. Putrid taste of pus or blood, salty, rotten egg or sulfate of hydrogen, it comes under tubercular taste. In footnote of aphorism 88 and 89, Dr. Hahnemann tells us about the importance of perverted taste in the mouth and the state of tongue during case taking. As he have mentioned about putrid, bitter and sour taste in aphorism 88 footnote. Hahnemann also mentions mouth as an important route for drug administration, where each dose touches thousands of nerves on the tongue and buccal mucosa and thus spreading the effects of drug to each and every part of our body. A miasmatic analysis. Thrush, stomatitis, dry tongue, yellow coated tongue falls under SORA. True ulcer of tongues are syphilitic in origin. Excessive salivation, moist tongue, deep fissure in middle of the tongue also falls under the syphilitic miasm. Psychotic miasm covers burning sensation and deep furrow in the middle of the tongue, gouty concretion in mouth of young baby born of psychotic parents, as we can see in case of tonsillar stones, stone of salivary glands. True ulcer may also be of tubercular origin. The characteristic of tongue of some drugs from hearing guiding symptom of our materia medica. First, antim crude. Tongue coated thick and white, milky white, yellow. As here it is given that it has been clinically confirmed in apyrexia. Much salty saliva in mouth, sore feeling and redness on border of the tongue, bitter mouth. White tongue in gastric catarrh. Now Antimonium tartaricum. Tongue very thinly white with reddened papillae, red edges, very red, dry in middle, red in streak, dry and red, cold pale, covered with a thin white slimy fur, which has been verified in cases of cholera. Tongue has a thick white fur, seen in rheumatism. Thick white or bilious fur on tongue with retching of phlegm, nausea and vomiting. Tongue brown, dry. Imprint of teeth on border of tongue. Small round ulcers with lard-like borders on tongue. Baptisia tinctoria. Tongue swollen, thick, talking difficult. Slight heat or burning at root of tongue. Tongue red and dry in middle, as seen in typhus fever. The root of tongue is swollen and feel numb. Tongue of a dark hue. Dry, parched, thickly coated tongue. Tongue dry, brown down center. Tongue at first white with red papillae here and there, followed by a yellow-brown coating in center, edges being red, shining. Cracked, sore, ulcerated tongue, seen in cases of typhus fever. Borax veneta. Cramp, numbness, and stiffness in tongue, impeding respiration. Aphtha in mouth and on tongue. Red blisters on tongue, as if surface was eroded. The pain from every motion of tongue, or if anything salt or spice touches them. Aphtha on tongue and inside of cheek, bleeding when eating. Aphtha are so tender that they prevent child from nursing. Bryanea alba, great dryness of tongue, mouth and lips. Tongue dry, rough, cracked and dark brown. Small aphtha on tip of tongue. Tongue coated grayish or thickly yellow with lips dry and cracked. White tongue with red edges. Tongue dry and red, brown, white or yellow. Tongue thickly coated white. Tongue coated white or yellow, especially in middle. Very much fur tongue, dry, white, filthy tongue. Causticum. Tongue coated white on both sides, red in middle. Verified in cases of epilepsy. Intolerable soreness of tongue as if scalded. Painful vesicles on tip of tongue, paralysis of tongue. Pain in tongue as if he had bitten it. Bites tongue during attack. Tongue and all around throat. Now in case of Crotalus horridus, tongue and all around throat feels tied up. He cannot speak a word. Tongue very red, smooth and polished, feels swollen. Tongue red and sore, yellow, stiff and numb. Tongue yellowish brown, dry in center. Foul tongue having red tip. Swelling of tongue till there is no more room in mouth with inflammation. Tongue swollen to nearly twice the normal size. Tongue protruded. Edema of tongue after sting of insect. Glossitis, erysipelatous or gangrenous symptoms. Syphilis of tongue. Cancer of tongue with much tendency to hemorrhage. Chelidonium majus. Tongue narrow, pointed. Tongue dried up, brown, cracked. Tongue inordinately dry or moist, of good natural color, but slightly coated white and sometimes streaky, the shape of it being narrow and pointed. Tongue pale, moist, whitish. Tongue red on edges and tip. Tongue red and sore with raised papillae. Tongue slimy, coated white or grey. Tongue thickly coated yellow with red margin showing imprint of teeth. Tongue covered with thick yellow fur. Fluoric acid. Tongue cracked in all direction. Multidirectional cracks. Tongue darting forth and back with great rapidity. Paralysis of tongue. Stuttering, imperfect speech. Tongue red, dry and rough. papilla enlarged, coated white, yellowish or brown, trembling, tip of tongue cold. Ipecacuana, tongue clean, yellow or white, pale, disinclined to talk, tongue dry. Lachesis, put tongues out with difficulty, tongue trembles, difficulty of moving tongue with impossibility of opening mouth widely, tongue black and bloody, cancer of tongue. We can see these two images, one showing the elongated tongue and the other the catching of tongue. Mercurius tongue swollen, flabby, takes imprint of teeth, pale white, tremulous, dry, hard, red and dry, red with dark spots and burning, moist with intense thirst. Tongue coated, showing imprint of teeth, thickly as if covered with fur, especially in morning. Black, moist, covered with mucus, dirty yellow with foul breath, black with red edge. Tongue inflamed, indurated, or suppurating with pricking pain. Natrum muriaticum, tongue coated with red insular patches, map tongue with diphtheria with amenorrhea, looks like ringworm on sides. Ringworm on right side of tongue. Tongue has a clean, shiny appearance or bubbles of frothy saliva along its sides. Numbness of lips from paralysis of trifacial nerves and numbness of one side of tongue from paralysis of glossopharyngeal nerve. Natrum phosphoricum, moist, creamy or golden yellow coating at back of tongue, blisters and sensation of hair on tip of tongue, pricking numbness of whole mouth. On rising in morning, tongue has a thin moist coating, a creamy deposit at back, or as if raw or yellow sugar had been partaken of. Natrum sulfuricum, dirty greenish gray or greenish brown coating on root of tongue. Tongue coated greenish with malarial symptoms, slimy, red, burning tip, blisters with burning pain on tip of tongue. Nitric acid, tongue sensitive even to soft food, bites it when chewing, sore pain, red like a beet, yellow, white, dry morning, green with tirelism, dry and fissured, white with sore spot, blisters with burning pain, small painful pimples on side, ulceration with tough ropey mucus, deep irregular shaped ulcer on edge. Nux vomica, tongue heavy, noticed in talking, speech difficult, lisping, unable to articulate, dry, heavily coated white or yellow white or brownish, black and dark red, cracked on edges, first half of tongue clean, sometimes red and shining, posterior covered with deep fur, red sore and yellow at base, painful blisters. Pulsatilla, tongue covered with tenacious mucus as with a membrane, dryness of tongue in morning, sensation on middle of tongue even when it is moistened as if it had been burnt and were insensible at night and in morning, biting in tip of tongue, edges of tongue feel sore as if scalded, tongue white or yellow and coated with tenacious mucus, parched, dry, no thirst, feels too broad, too large. tongue greatly swollen, dorsum bright red and covered with a network of dilated and congested veins, varicose swelling on left side of tongue, use of tongue greatly hindered, tensive burning pains, no fever, mental and physical depression, hemorrhoids, gout, rust toxicodendron, tongue dry, sore, redness at tip, not coated but very dry, which provoked drinking. Tongue dry, red cracked, has a triangular red tip, white, often on one side, yellowish, covered with brown mucus, takes imprint of teeth, blistered, coated at root, yellowish white, thickly coated, brown mucus, excepting on edges, in morning on rising. Sepia, tongue and cavity of mouth filled as if scalded. Tip of tongue filled, scalded. Soreness of tip of tongue, little blisters, sore edges. Tongue painful as if sore. Tongue pale, flabby, and indentated. Blisters on tongue and pain as if burnt. Vesicles on tongue, tongue coated white with mucus, dirty yellow, brown with red edges. Talking is only a stammering, tongue stiff. Syphilinum, tongue very red and thick, covered with herpetic eruption, two deep cracks running lengthwise on each side of median line, making it difficult to swallow. Tongue thickly coated, dirty, edges indented or serrated by teeth. 20 ulcers in mouth, every part of which was involved, on top and underside of tongue, on lips, in buccal cavity, fauces, and in nose. Two large ones, one on each side near apex of tongue, very much swollen, one on right side had a gangrenous center, raised lardaceous bottoms with bright, fiery red edges and were cut down as with a knife, felt hard like an indurated sanker. Septum of nose threatened, both alanazai very painful, smarting with burning as if on fire. Pain and burning prevented sleep, hungry but could eat nothing but fluids as mastication was impossible. Tongue heavily coated white, large quantities of stringy viscid saliva running from mouth of a sweetish taste, a putrid sickening odor filled whole house. All symptoms aggravated towards night. Thuja occidentalis. Small white vesicles on tongue resembling miliary rash, a white blister on side of tongue, close to its root, painfully sore. Ulcers of roundish shape under tongue in a child after vaccination. Its age consists of a number of pointed condylomata which could be separated by a fine probe. Tongue swollen on right side. Semi-transparent, jelly-like tumor, bluish tumor size of a small walnut at root of tongue, left side, painless, soft. Impeded speech, first noticed 9 months ago, is liable to swelling of glands of neck, slight swelling of thyroid gland. Now let us come to the repertory part. In Kent repertory of homeopathic materia medica, tongue is given under the chapter mouth. In BBCR, tongue section is given under mouth chapter from page 462 to 469. In BTPB, tongue is given under mouth chapter as two rubric, tongue and tongue coated from page 63 to 64. Some of the rubrics of tongue in Kent's repertory. Blotches under the tongue like vegetables growth. seen in Ambragresia. Cracked tongue, fissured in all direction. Fluoric acid, nitric acid. Discoloration, tongue, red, tip, triangular. Rustux. Discoloration, tongue, white, side, causticum. Motion, tongue lapping to and fro. Cuprum, hyoscyamus, lachesis, sulfur. Nodosities, tongue on tip, hard forming vesicles resulting in unclean ulcer with hard edges, phosphoric acid. Pointed tongue, calcarea, chelidonium, lachesis, petroleum. Taste metallic, food taste, ammonium carbonicum. Taste nauseous, smoking from pulsatilla. Taste putrid, meat taste pulsatilla. Taste putrid, hawking when nux vomica. Taste salt enough, food only tastes natural, lac caninum. Taste sweetish, bread tastes mercury. Tumor, tongue, rounded elevation in the center, size of P, sensitive to touch, withdrawing sensation as if a string were pulling center of tongue towards hardwood, seen in Castodeum. Varicose veins, tongue, hamamelis, pulsatilla, thuja. Here I would like to present two cases. One case is of a child aged 5 years, came to OPD in the month of June, dated 23rd, 2022, with complaints of pain in abdomen, which was aggravated by eating fatty food, and pain got relieved by rest and passing stool. The child was constipated, has desire for sour, and has tongue markedly coated with thick white phlegm. The child looked dirty, obese, doesn't wish to bath, and was angry at every little attention. Now, here we know that thickly coated white tongue is a characteristic indication for antimonium crudum. Also, based on the other symptoms, the child was prescribed antimonium crudum 201 dose, followed by placebo for 2 weeks. After 2 weeks, the child was found better than before, and placebo was continued for next 2 weeks, after which the child was totally relieved. Second case is of a case of a young girl of 18 years who visited our OPD on 17th November 2022, having a lean, thin appearance. She was anemic, complained of headache with blurring of vision, aggravated from noise, light. Her pain was better from fasting. She has habit of taking extra salt in her food and desire for fish. Stool, constipated, also suffering from involuntary urination while coughing, sneezing. Her tongue was mapped with red patches on side. She was irritable, introvert in nature, weeps alone in bathroom, and consolation makes her worse. So the picture clearly shows a case of natramur, and she was prescribed natramuraticum 0 by 1 16 dose AD for 32 days. Then after 1 month she came and reported that she is much better than before. Natramur 0 by 2 16 doses was prescribed for alternate days, which cured her completely. So now after seeing all this, we can easily differentiate between the common and uncommon forms of tongue presentation for remedy selection. As we know that we as a homeopathic physician are concerned with the uncommon, peculiar manifestation that takes place and which helps in the selection of our medicine. So, for instance, if a person suffering from Parkinsonism present with to and fro movement of the tongue, then it has no homeopathic significance because it is the symptoms of disease, not the patient. But if the patient is not having Parkinsonism but still comes with such a presentation, from our homeopathic point of view, it is of extreme importance and a characteristic indication for us which will help in the selection of our remedy. Similarly, if a person is suffering from iron deficiency, he or she will develop smooth, depapillated tongue. Then we should first correct the existing deficiency state. And even after correcting this deficiency, if the patient present with this type of tongue or the tongue condition exists, then it becomes important and it guides us that there is some deep-seated miasm lingering on the patient. These are the bibliography. Thank you. Thanks to all the respected viewers for your patience.
Thank you, Dr. Bhaskar. I must congratulate you for your beautiful presentation. So, I know Dr. Bhaskar personally. He is my colleague at Calcutta Homeopathy Medical College and Hospital. He is a very good doctor and a very hardworking, studious, and he did justice with this topic. His actual topic is the clinical importance, clinical importance of tongue. Tongue is clinical importance. His total presentation started with the anatomy and he included all the clinical aspects. One clinical aspect, being the homeopathic physician, related with tongue, we have two aspects. One is the clinical diagnosis from modern medicine aspect. He beautifully covers the that things where with the help of the tongue we can do the general survey, the clinical diagnosis, how the tongue helps in diagnosis of various clinical disorders or diseases, including the congenital problems also. He included his in his lecture beautifully. So this is one clinical aspect. And another thing, in the second part of his lecture, he beautifully described the miasmatic angle related with clinical aspect of tongue. He beautifully described from Materia Medica. It is expected from him. He is a Materia Medica teacher from the Materia Medica department, Materia Medica faculty from the Calcutta Homeopathic Medical College and Hospital. So he beautifully pointed out different angles. I myself personally enriched a lot from his lecture, today's lecture. And another thing, then how the tongues are helps from different angle. First, from being a homeopath, which are important. The first thing, the taste disorders of the taste, like the bitter taste, pungent taste. One thing that is taste related with tongue. Then the appearances of the tongue, the strawberry tongue, matte tongue, etc. This is another angle that helps in selection of the medicine. The symptoms related with tongue, it is a particular symptoms to us. These symptoms are very important in selecting our medicines. Often the symptoms are the characteristics, the uncommon peculiar characteristic symptoms of the medicine and the patient. So it helps in selecting the medicine in many ways. I can recall one case. I can recall one case when we were in PGT at NIH. One day, when the OPD hours over, the PGTs from the different department at that time, only the three departments were there: Metria Medica, Repertory, and Organon. Few PGTs uh, after the OPD end, and before we going to the hostel or the departments, we were spending some leisure time and discussing some different topics. One patient comes, one family comes with a person comes with his son. It is the age of the son is 8 to 9 years. The person belongs to the faculty of some renowned engineering college. He asked for Professor Dr. Adhikari sir, and I was working in his under him. He was my guide. So at that time, Adhikari sir leaves the OPT. He was busy with some other official works at NIH, some meeting, an important official meeting. So it was next to impossible to visit him after the OPD hours. But the parents of that young boy was very eager and was requesting me to meet him. They are directly coming from Peerless Hospital. The young child has the head injury, and the CT scan showing blood clots, and they advise to come after 1 week, and they will drain the blood if it is not dissolved. But they told that after come after 1 week, and it may if operation surgery is required. If not surgery is required, it will take 6 months or 8 months to dissolve the clots. But all the PGTs were thinking about suggesting many medicine, and starting from arnica, symphytum, etc., etc. So medicines come. So, but uh, the patient was as the patient was very requesting, and I along with me, I go to the department, and Dr. Sir was at the one meeting. Sir, just see, sir just told, to ki koris tora, and no, sir, please see the patient. And sir, sir, just see, show me your tongue, just see the tongue, and sir gave Nactamine, give Nactamine 0/1. Okay, the sir কেন দিলেন এখন বলবো না, যা গিয়ে you go and give the medicine. So I go to the pharmacy and arrange the medicine. And after, and in between time, just I forgot the patient. After 1 week, the patient again come and meet sir in OPD with a new CT scan. There was no bleeding was there. No blood is there. No blood clot is the brain. CT scan showing. It was a miracle. It was not possible to disappears all the large blood clots within 1 week. Then okay, then I asked sir, ebar to bolun, why you give this medicine? Please now tell me, why you give medicine? Why Natramir? Why not arnica? Sir told me, you have observed all things but not the tongue. The patient had mapped tongue. So under mapped tongue, so many medicines are there, including Natramir. And sir advised me to open the repertory. When I opened repertory, in under head injury, there are only 5 medicines are written from arnica, cicuta, natramur, natrum sulp, and hypericum. And sir, just only to the sun, and is only to see the tongue, mapped tongue, and the head injury, he gave natramur, and the result was miracle. So anyway, so in our everyday practice, tongue helps us a lot in selecting the medicine. I am not telling that tongue is everything, but the symptoms of the tongues are often become an important part of our totality of the symptoms. We always select the homeopathic medicine on the basis of the totality, and tongue is one of the very important symptom, one of the very important uh, part of this totality. So anyway, Dr. Bhaskar elaborately uh, delivered his speech, and I think we all enriched with his speech, from the anatomy, its nerve supply, its uh, applied aspect, its different deformities related to the tongues, congenital deformities, and all things, and then homeopathic part. There is nothing to say more. I am not wasting much time. So our next speaker is Dr. Ujjal Mondol, former Deputy Superintendent, National Institute of Homeopathy. Dr. Ujjal, when we are doing PGT, we have done our 1 year uh, house job sieve as a part of PG curriculum under him. So I know him. He is a very good doctor, and I think he has much knowledge about the surgical conditions, so-called surgical conditions, and I think he is the right person for this topic. And I am eagerly waiting to hear from Dr. Ujjal Mondol sir, and experience, hope his knowledge will enrich us. Sir, please start your lecture. I am inviting you. Please, sir.
Good evening, Debashis and others participants this night. Hello, can you hear me? Achha.
Yes, sir.
Hello. Hello.
Yes, sir. Yes, sir. Yes, sir. We can hear you, sir. You continue.
Okay. Uh, now, Arko. Hello.
Yes, sir.
Achha. Good evening. Can I share my PPTs?
Sure, sir.
Okay, sir. नीचे आ जाओ. Is it visible?
It's visible, sir.
Okay.
Please click
All
on
right.
the hide button right beside the stop sharing one. Ah, now
Okay.
turn on the slideshow. Turn on the slideshow. Slideshow. Sir.
Okay. Good evening.
Everything is visible.
Achha. Okay. Good evening. Thank you for giving me this chance to speak about the anorectal disease. Actually, in NIH, my tenure was 20 years. I was happened to be in surgery RMO, and so many cases was referred by other OPDs. Also, patients come directly to our OPD for anorectal diseases. So most of them is I have observed some of the cases was taken by Dr. Junjunwala for operative, and in my OPD I have treated so many patients of mainly hemorrhoids, fissures, and occasionally also fistula and abscess. So now I am going to start my slideshow. Now this is as we know, the anatomy of length of rectum, as we know, 14 centimeter, anal canal is 3 centimeter long, all this. And there is the denuvilous fossa, rectangle fossa, separate fossa and vagina for rectum. Rectococcal fossa, Wilder's fossa, both fossa act as a barrier of rectal metastasis. Now come to the anatomy of the rectal canal. So this is the anatomy of rectal canal, as you see in the picture. So blood supply of the rectum is superior rectal vessels, which is a branch of the mesenteric artery, main vessels are hemoidal artery, middle rectal vessels, inferior rectal vessels. Lymphatic drainage follows vascular supply mainly towards superior rectal vessels, then to porta-aortic nodes. Hemorrhageal veins, branches of very thin protection, very small. Injury during defecation causes bleeding due to compress and due to contraction of rectal musculature. So what I said, hemorrhoids, the anal canal is divided in two valves. upper and lower. Upper half has a longitudinal folds or elevation of tunica mucosae. Its mucosa is lined by simple columnar epithelium. Its upper half of the anal canal is supplied by, as I told in the preliminary, the physiology of anal continents is act as a reservoir function. Normally, the distal rectum remains empty and collapsed state due to the lateral angulation of the sigmoid colon and the valves of Houston, also related to progression of fetal fecal material. Moreover, weight of stool enhance these angles and enhance their barrier effect. Motor activity is more frequent in contractile waves are higher amplitude of the rectum than sigmoid. These reverse pressure gradients resist the caudal progression of the stool. Sphincter factor is another, as the most of the commonly accepted, the expansion of the continents of the higher pressure zone of the anal canal. The rest at the rest 20 to 125 mm per Hg provides effective barrier against the pressure in the rectum. Both the internal and external sphincter contribute to the resting time of the anal canal. At continuous titanic activity at rest and levator ani, external sphincter muscles exist even during sleep. So this is the actually anatomy, all these things. Now coming to the next, the type of hemorrhoids is the internal and external hemorrhoids, as you know. The rectum and anal canal artery, veins and lymph supplied, as I've shown this picture. The veins of Houston, as is shown here. Inferior mesenteric vein, venous supply. Hemorrhoids are normal anatomical cushions made of venules, arterioles, smooth muscle fibers, and elastic tissue. And classical location of hemorrhoids, as we know, that 1 o'clock, 3 o'clock, 3 o'clock, 7 o'clock, and 11 o'clock. This is the picture. What the mostly the if you when you examine with proctoscopy, these are the site we can visualize the actually color. There's a pink or color of vein is there is some color changes in the disposition by only by proctoscopy, not by the DRE. What's digital examination. Pathology is on contribution to excessive straining, followed by abnormal descent of anatomical cushions, injury by hard fecal matter, followed by painless bleeding. It is one of the says that goes varicosity is penalty of vertically against gravity. Other than straining and constipation, main complaint, patient reports, hemorrhoids have a canal resting higher than normal. Low fiber diet is another reason which result in straining and defecation. Hemorrhoids occurring following situation also pregnancy, portal hypertension, inflammatory bowel disease, obesity, etc. The nerve supply of hemorrhoids is the inferior hemorrhoidal nerve, which is very painful. Main complaint is bleeding or rectum. Main complaint of significant lower GI bleeding, colonic diverticula, clinical presentation is the painless bleeding, mucous discharge, and collapse. Amount of bleeding is 3 to 5 ml, maximum 10 ml. Complication, profuse hemorrhage most often occurs early stage or second degree of hemorrhoids, followed by strangulation, collapse, internal files gripped by external sphincter and lead to further venous congestion and impaired and lead to strangulation. If not treated, lead to thrombosis and gangrene. And main complication is hemorrhoids is pain and complication is retention of urine. The diagnosis, this can be palpated, therefore cannot be diagnosed by digital examination. Diagnosis of hemorrhoids only can be diagnosed by proctoscopy or flexible sigmoidoscopy. And the early 10th or 12th, 2012, where we started also sigmoidoscopy in our OT, and so many patients were examined through sigmoidoscopy and colonoscopy by Dr. Junjunwala, and so many patients were record was there, but fortunate that we could not collect this report from our source, That was the part of our reluctant or whatever say we do not remember our history. That is the fault of our side. Now, grades of hemorrhoids. First degree is never plus, bleeding per rectum only. Second degree prolapse on defecation with spontaneous reduction. Mass per rectum, everybody knows all these things. Rectum descends down. Third degree prolapse on defecation required manual help or reduction. Mass per rectum, bleeding mucus, discharge fluids. Fourth degree is permanent plus, bleeding, acute and discomfort. Actually, I say homeopathically, we have very good result in first degree, second degree, and also partly third degree. But fourth degree, we do not have very good result. That cases, in my knowledge, what we have seen so many patients of prolapse or whatever piles prolapse that are better to treat by surgical intervention. It's my knowledge. Whatever it may be differ to other physician to physician. These internal hemorrhoids and external hemorrhoids. Types of hemorrhoids, as it also discussed, dilated hemolymphatic plexus located below dental line. This is acute thrombosis, pain from rapid distension of inverted skin by clot surrounding edema, resolution to excess skin tag, internally exaggerated of submucosal vascular tissue located above dental line, arranged 3, 7, and 11 o'clock. 4 categories, namely first degree, third degree, second degree, third degree, fourth degree hemorrhoids. Already discussed. In Kane's bursary rectum canal chapter is indicated type of hemorrhoids is bluish, 14 medicine among this. First grade is 4 medicine, asculus, all these things, and congested in 25 medicine. In my practice during service period, and what I observed, as I told you, anorectal disease frequently following medicine. This is Nux vomica, acid nitric, aloes, asculus, collinsonia, calcareous floor, hemamelis, lachesis, datania, causticum, peonia, sulfur, etc. Hemamelis also medicine is also selected according to science. All these medicines are selected to scientific. But what have I observed that hemamelis, acid nitric, retania, ascular, collinsonia, these medicines are really works very fast in my knowledge. Along with, you have to see the management also very important. Management is part of also, as you know, that Sijbath is very important, and diet modification to watch regular bowel movement also important. As we ask patient not to take mutton or which may create constipation, avoid all this food. Drinks much more fluid or water, and take fiber diet too much for patient to get this relief of this. Actually, management can give you 50% to 40% relief from the difficulties of hemorrhoids, all these things. Hemorrhoids are also fissure. Case study, I have taken a study with one my intern, which was as a dissertation in the year 2011, 15th batch of intern Vinod Kumar, under my supervision. As we know, the sulfur, folic acid remedies has action so many times, but we have taken the sulfur. 20% was selected with this, and 10 was given same sulfur, and 10 was given the placebo. These are the polar this all these things. Borysmeria, Allen skin node, stool hard. The symptom of sulfur is taken from all these books. Other than sulfur, hemamelis, collinsonia, calcareous floor, lachesis, prolapse, constitutive piles, color, urging rectum not for stool. This is the case which was, dissertation which was taken that time. This is one of the picture I've given in my presentation. And this is the acronym by Vinod Kumar, who was this the intern. He has also taken very sincerely done all these cases. 2-3 cases I can, as Tyler said about the sulfur. Now come to the another disease, anal fissure. As we know, this is the also result of anal fissure. There is a longitudinal tear in the end of rectum. 90% of anal fissure occur in the posterior part of the anal canal, and 10% in the anterior part. So, how you know that this is the anterior and posterior? Keep a watch of the patient abdomen. 6 o'clock is the anterior, and posterior is 12 o'clock. So this is the due to pain in internal sphincter Spasm causes worse the constipation, which result in chronic fissure. Anterior fissure occur elderly women due to repeated pregnancies mostly. And this is the result, fissure is a result of constipation, hard stools, fissure and pain. Main complication is fissure is also pain and urine retention. Various factors precipitated anal fissure is the facies, heart, I for ischemia, S for surgical procedure, post-hemorrhoidectomy also cause a fissure, sphincter hypertonia, repeated childbirth, enthusiastic usage of ointment or abuse of laxative. Clinical feature, as you see, is the severe pain due to defecation, burning anus, take long time to pass stool, hard stool with blood sticks or fresh blood after passing stool. Acute fissure sudden onset on vaginal delivery following hard stool. Acute pain, bleeding, per rectum no sentinel piles, small crack in lower anal canal, severe sphincter spasm. Chronic fissure is, if this continues, symptoms continues for a long time, patient may develop the chronic fissure in ano. Homeopathy, mostly antibiotic medicine are used, having very good result. In NIH OPD, huge number of patients used to refer by other OPDs also for diagnosis and treatment. And direct patients also visit the surgical OPD with anorectal complaint. After examination, most of the cases I found hemorrhoids or fissure in ano. The number of fistula and prolapse and abscess are less. Following meds are sedate frequently, as I told you also in the hemorrhoids. Acidic, some common medicine are also acidic, hemophilis, retinitis. Most of the cases I have got very good result within 2 days. Vascular shape, Brownia, Collinsina, Causticum cells also this medicine help. Pimids are very commonly used. Fissure, this I told you all in fistula, that is Calcarea fos, Causticum, Salacia thuja. And another is that lachesis, prolapse, Collinsonia also sharp, as you see the symptom of colon sharp stick in the vascular and prolapse files and constipation during pregnancy, all these things. Graphite is also very good medicine for fissure. Retinia fissure with terrible pain after stool with burning relieved by cold water is for retinia very good medicine. Magnesium ure, constipation from inactivity of the rectum, anus contracted turn, bleeding and severe paining. Pain after stool and pain after stool and severe burning is acidic also in fissures. So these are all medicines. And one thing is that after this completion of whatever treatment we are giving, if you give the one antisoric medicine to get good result, is sulfur is very important. What I have observed, or 50 milligram medicine of sulfur is very important after all this patient to get the complete relief of the symptoms. But along with that, patients have to avoid the constipation, otherwise further may occur this fissure. Now, anorectal abscess, as you know, the abscess patients come when not in very acute stage, but early stage we get the hard swelling around the anus. And if you treat our homeopathy medicines, which indicated like belladonna, sulfur, or silicate, whatever it may be, we got good result. But if you want to suppress the abscess or boils, that is Calcarea curve 1M or 10M, what we have seen. Dr. Sarkar has one time, when I was in DPNH, we went to one abscess patient and boils in the around anus, and he told, please give him Calcarea curve 1M and 10M. Within 7 days, this abscess is disappear and patient is not develop anything. But one thing I am mentioning you, please, whenever there is abscess, if you not treated it properly, that may lead to the fistula. That is another very common complication of abscess. If not treated, it may lead to sometimes fistula. There is 3 type of abscess there: perineal, ischial, and submucous, and pelvic rectal. Ischial rectal abscess, as you know, ischial fossa is there, and there is a very deep abscess, and that sometimes you may not see with observation. Sometimes you need help of USG, guided FNAC, or anything else to remove the pulse or give the homeopathy medicines for as per sign and symptom. As we know that the abscess is a result that will give the clinical feature of fever with chill and pain. All these same symptoms occur, and localized pain also in the area. And causes of abscess is that infection and diabetes and AIDS. Diabetes people are mostly very vulnerable to this abscess. Now, fistula, abnormal communication between the anal canal and rectum result due to anorectal abscess. Rupture inside wall outside does not heal and persist for a long due to infection as low vascularity and resting face. Standard qualification is subcutaneous, submucous, low anal or high anal or pelvirectal. So fistula is also I request to all of those who are early or treating homeopathy medicine early stage or those are treating starting in practice early period. Fistula you have to treat very long time. It is we know that it is a tubercular, mostly tubercular or mixed myasm. So you have to take the medicine according to symptom similarity for treatment of the fistula. Sometimes calcarea, phos, silicea, sulfur, Verbis vulgaris, all these are medicine only selected in the fistula and ano. And this medicine also indicated some abscess, also anal abscess according to discharge. Prolapse rectum, that's a very, we have seen prolapse rectum, but we have did not treat so much prolapse rectum in our OPD because actually what I have seen that this needs some surgical interference, otherwise very difficult. But if it is chronic prolapse rectum, if it is in case of child, sometimes you see that some there is something is coming out per rectum, but it is not, don't treat it as a prolapse, something is polyp. So if polyp, you can treat the polyp according to symptom similarity in early in the child, in case of child. So polyp is also, we will see this is something is, when you per rectal examination, you can see that we have seen some, how many people have, if you have object examine the rectum during this complaint, then we can see that a child have some polyp in the rectum, and that causes also bleeding, and that also bleeding is very high. So that time also we treat some homeopathy medicine or whatever maybe to go to modern medicine for it's a simple operation, nothing to teach, just one tag is there, just tie it and cut it. Complete prolapse, female and male ratio is more in female than male. Obstetric trauma is another cause. Multiple vaginal deliveries cause pudendal nerve stretch. Prolonged labor disrupts the sphincter and stretching of the pudendal nerve. Third-degree perineal tears weaken the internal sphincter. This is the complete prolapse case. As I told you, aloes can be used also in the prolapse piles, or sometimes you see the piles is also coming out per rectum, and there is a grapes like a structure around the rectum. And we ask them patient to go for sea bath, reduce the swelling, and also give the homeopathy treatment, slightly reduce and goes to the inside, and then you go for the homeopathy treatment long time, it may get you relief. So this is my presentation. Debashis, I am watching for after a long time. Thank you. So my conclusion that fistula and hemorrhoid, fissure and hemorrhoids can be treated homeopathy very good result. Fistula I have did not get very good results, or number of patients I did not treat maybe. And pull-ups also, I did not get very good result. But hemorrhage and fissure and abscess, you will get good results. Thank you.
Thank you, sir, for your beautiful presentation. After a long time, I am hearing you, and your presentation was full of your practical experiences. You have shared your experiences with several anorectal conditions like piles, fissures, fistula, prolapse rectum, and anorectal abscess. So it's a very good presentation, sir. I have nothing to say with your presentation because I am your student. So it's a very good presentation in one word. Now I have enriched a lot. We all expected. We all have enriched enriched a lot. Now, with due respect, I would like to add few of my clinical views on this anorectal problem, anorectal complaints. Present day, the anorectal problem, I think it has been increased a lot due to fast lifestyle, diet habit, or whatever may be. So, one medicines, the sedum acre, I have given few patients. I have read it and from the Borix America, and I have given to some of the patients. Some uncommon medicines are there for the anorectal conditions. One is sedum acre. It is a very good medicine for uh, hemorrhoids and the fissures, and there is a pain like that anal fissures. In hemorrhoids, if there is pain like the anal fissures, and the pain persists long after the stools, sedamacre is one of the very good medicines. Some other medicines like peonia. Peonia is a good medicine if the indications are present. Then Lumia odorata, hemamalis. These are often used to relieve the acute symptoms of the piles. We often uses this. And over and above, as you told, totality of the symptom, covering the miasmatic background, it is the last word. But and a few days back, I have treated one patient with 80 years patient, which were presented with some bleeding per rectum, and on examination there was a prolapse, rectal prolapse. We prescribe Ruta, and at least the pains release, bleeding stops. The patient was relieved. So there are a lot of scope of treating the anorectal problem with the homeopathic medicines. So thank you, sirs, once again. And every day, all the homeopaths who are practicing rural area or in the towns areas or and even the cities, they often faces the several anorectal conditions. Patient fears to go to the surgeon for the surgery, and all the homeopathic physicians are treated the anorectal problem with their efficiency and successfully. Another thing, along with this, in NIH at that time, in NIH, there are so many conditions. Patients comes with the rectal carcinoma also, and the in NIH OPD, there is at that time the patient comes with rectal carcinoma. We treat on the palliative manner, and successfully palliate the so many conditions. Anyway, so there are one suggestion from Dr. Pritha Mehra. So Dr. Pritha Mehra, there is one suggestion that she told that respected Kalyani sir and Bidyut da, I have a suggestion. It will be great if the presenter can make a table with picture of tongue, its description and related clinical condition. This suggestion is for Dr. Bhaskar, and uh, another this the Dr. Pitha also suggested that this whole aspect can be structured. This whole similarly, the miasmatic aspect of the description of the tongue may also be provided in a tabular form. Yes, and the cases which he has presented may be recorded along with the photographs of the tongue before and after treatment. And another is this whole aspect can be structured in a manuscript from the manuscript form and submitted in the journal for publication in a Alumni Association journal. One thing in this regard, I can say tongue, that previous comment, your previous suggestion. So the cases which are presented may be recorded along with the photographs. Yes, tongue. When we are prescribing on the basis of tongue, we are not treating the tongue disorder. We are treating some other problem away from the tongue, and we are taking the tongue symptoms, symptoms related with tongue, its descriptions, its appearance, its ulceration, or whatever may be. This is the part of our totality. It may happen, it happen usually. Suppose if a patient comes with the large, flabby, moist, indented tongue, the syphilitic tongue, we prescribe medicine on the basis of the or at that time on the dominating miasm background, any anti-syphilitic medicines like mercurius, or whatever may be, the from antisyphilitic group of medicine. After taking medicine, it may happen the major symptom, other symptom totality changes. Now the patient comes after 1 month or 2 months with some other characteristic, dry tongue, dry, dirty, coating, dry tongue, like psychotic tongue. This is homeopathy. At that time, the internal vital force need antisyphilitic medicine, so it was deflected through the tongue with syphilitic tongue. Now when the patient comes with a psychotic tongue, then this is the called change of plan of treatment. This is the thing. This is change of plan of treatment. So tongue is an indication. We are not treating the tongue. Tongue symptom here in a chronic case taking, tongue is an important part of totality. Okay. So I think this is my opinion. And another opinion from Dr. Probir Mojumdar. What are the treatments of homeopathy for pentasomatic somatosis of tongue? What are the treatment of homeopathy for severe dryness of the rectum after surgical removal of fistula when failed repertorial guide? So one first question is for Dr. Bhaskar and second question is Dr. Ujjal Mondol sir. So I am requesting Dr. Bhaskar first if he can give any suggestion, if he give the answer of the queries. Dr. Bhaskar, please. Dr. Bhaskar, are you hearing me?
Yes. Yes, I am here.
So please share your knowledge.
Yes, the question is, what is the treatment of homeopathy for pentastomatiasis of tongue? Usually the problem resolves within a month or two, but as homeopathic physician, we can take the case, the totality of the case, and select the most similar medicine for the case. Thank you.
And Dr. Ujjal Mondol sir.
Yes. No, actually, what is question is that after treatment of homeopathy for severe dryness of rectum after surgical removal of fistula when fail repertorial guide. No, actually, surgical physiology it is done fistulectomy. This is the only fistulectomy is done, not the removal of a fistula. And if after fistula is removal, that does not go. If it is goes the rectal anal canal, then it is another big operation or big operative site. If it does not goes this one to another end, channel is got gone to a rectal end, then it does not occur the dryness of mucous membrane of the anus. If it is goes channel goes up to rectum, then it is very major operations for this fistula operations. And then if it is dryness is there, that we have to treat accordingly according to sign and symptoms only, and patients have to ask for diet modification also. This.
Thank you, sir. Thank you, sir. And thank you, Dr. Bhaskar. Dr. Bhaskar have told that the pentastomiasis is a zoonotic disorder, a parasitic disorder of the tongue. Like all other conditions, we should take it like the other diseases and select medicine on the indication, on the totality of the symptom. Okay. And Dr. Ujjal Mondol also said that the same thing. In homeopathy, we have one thing in answer. We have one answer. We should give medicine on the basis of the totality of the symptom. In both the cases, both the honorable speaker told the same thing. Okay. And is there another question? Any questions? I think there is no further questions. There's no queries are there. So thank you, sir, Dr. Ujjal Mondol sir and Dr. Bhaskar Bhattacharjee, today's speakers.
Dr. Debashis, I have one suggestion.
Yes, sir.
My suggestion is those who have passed out or still reading any PGTs, they have a lot of materials to deliver lecture in CME. My request is to all the PGTs who has passed out or reading, because you people have every week seminar in our college. Every week you are presenting cases from your department. So I am requesting to all PGT to come to this platform and give the lecture on their topics. What have they given in CME on their weekly CME presentation?
Thank you, sir, for your suggestion regarding this. Our president, sir, will think about. And anyway, handed over the screen to our president, sir, Dr. Narayan Kalyani, sir.
Uh, thank you very much, Professor Devashis. Biswas. Many thanks to all the participants on screen and out of screen, especially to our beloved sister, Dr. Devajani Saha, is a brilliant student of Alumni NIH from Bangladesh. Professor Debashis Biswas for nicely, excellently moderating the session, whole session. Equally, I pay my heartiest thanks to Dr. Ujjal Mandal for his brilliant presentation. It's a very short, brief, and nice presentation covering all the fields. Equally, I am really very happy and I pay thanks to Dr. Bhaskar Bhattacharjee for giving a brilliant presentation which will be an asset. But in my opinion, today's CME is an asset of Alumni Association. All of us, we can preserve it, we can read, we can repeat it, we can see and increase our experiences. Regarding Dr. Mondor's suggestion, see, we must try to convey this, your suggestion to all the PGTs that whoever alumni hears a single case, it is his moral responsibility. In my opinion, it is religion in homeopathic system. Principle must be that should be conveyed to other alumni and students for enrichment of knowledge of all of us, by which we will all together will be able to take homeopathy system of medicine progressing and gradually increasing in strength. Definitely must try to convey this information. Very nice suggestion from Dr. Mandal to inspire PGTs and others those who are presenting cases in NIE that should be given to alumni also, as alumni are trying to give their experiences to all of us. Now, regarding the first lecture, that is a brilliant I told you that this asset of this year will be an asset of alumni. Tongue, in repertory, it was given a particular area, either in the stomach or some other chapters. But in practice, by our experiences and by our talks, we have seen and we have presented the tongue symptom in physical general symptom. By lectures of our course today, we are reconfirmed that tongue is such organ, presentation, vision, and clinical indication of tongue is not only of tongue, but also the whole system as a whole. That's why it's a very important physical general symptom in homeopathic system medicine. Many times that guides us to the particular drug, as we heard about nectar regarding brain hemorrhage. Another thing, anorectal problem, as our moderator was telling, day by day we are inviting artificial life. That's why the cases will gradually go on increasing due to different irritant substances getting into the system. And by drug hazards, gradually we are intoxicating the liver and digestive system by taking conventional medicines in good number. As a result, portal hypertension, disorder in absorption, disorder in digestion, it has become a regular factor for many people. Nowadays, we will heard the majority of the senior persons, they are suffering from IBS. Many people are suffering from IBS and rectal disorders. Day by day, this will increase. Many years before Hahnemann was very much confirmed that these diseases are not true surgical diseases. they are pseudo-surgical disease. And we have experienced by number of cases as Dr. Mandal presented, many of us having the experiences that really anorectal disorders are not truly surgical disease, it is pseudo-surgical disease. If we try sincerely, we can cure it, except very few cases like severe collapse, etc. But one thing I must remember you that nowadays rules, laws has become very tough. To prevent disturbances, we must not neglect this type of two diseases. One is tongue patches. If it is the leukoplakia type or white patches for a long period, especially for elderly persons with a history of carcinogenic elements intake, we should never forget to test cancer marker and for a biopsy of the patches. Otherwise, if we go on continuing the treatment, if it doesn't cure, we may face negligence of responsibility court case. If the case is detected cancer and by this time it got metastasis in different other organs. Same thing for anorectal bleeding also, ulcers also, not that much of fistula, but bleeding, especially without pain, infrequently, even by slightest constipation or without constipation, often elderly people with a history of carcinogenic elements intake. We should never forget to test cancer marker first, then colonoscopy or proctoscopy or other investigations, CT scan, MRI, to get rid of these cases, court cases, that is negligence of responsibility. It is definitely costly. Many patients may not bear it, but we should not forget to mention in our prescription that this is advice. If you can do it as well, if you cannot do it is your responsibility. So, repeated bleeding, persistent bleeding, with or without strains, constipation in rectum, and patches on tongue, we should never forget to exclude malignancy. For these two type of diseases, I can share my experiences, and you can read Boris Mathematic also. Echinacea is a very good medicine. If we find there is no other particular indication, homeopathic generality is lacking, or homeopathic generality is not able to give that much of improvement due to some other strong pathology, we can think of echinacea to restrain, to reduce its complaints and other things. You can test and verify. So anyway, as a whole, really today's CME is a brilliant CME. I welcome all other alumni to come forward to share their great experiences, and I am very sure that many of you have excellent experiences. Will be very much helpful. All of us will be thankful to you if you come forward. And I request to this speaker, moderator, inaugurator, all to come again with their experiences on other subjects to enrich our knowledge for the propagation of homeopathy up to our desired extent. Thank you very much and good night. I request Dr. Mukherjee to make an end of this session. Anyway, there may be some other problems. Orko, do you hear me?
Yes, sir.
Please.
Oh, okay. So taking over.
Dr. Mukherjee, if Mukherjee is not there, you can make a name of the day.
No, he is in. He is in. I'm taking myself out, and he is in.
Okay. Please go ahead.
Hi, good evening. Sorry, due to network connectivity, I'm just back home. I was listening to such excellent presentation, and I missed a bit. One thing I always say: when there is a will, there is a way. Uh, I am still out of station, but uh, the one thing which we try to infuse on everyone that we should go ahead with the CME and what Pritha had suggested to get the crux of the CME and put it in the journal. So this is a collective teamwork, and we salute our teamwork, our team members all through and through. And thank you all those who had been presented today, and Sir being a great inspiration to all. Uh, Still in this cold and in this weather, sir is still so vividly guiding and leading all of us through. Thank you, Kalyani sir, for your efforts and endeavor. And thanks, Ujjalda, Bhaskar, Devashish, and
Thank
Devjani,
you. Thank
all
you.
of you.
Thank you. Thank you, Bidyut.
Thank you very much.
And with this,
Thank you,
we
Narayan.
are going back. We'll be meeting
Thank you.
again on, thank you. And we'll be meeting again on fourth, fourth Sunday, which is today's 8th, on 22nd of January, with a new set of speakers, inaugurator and moderator. For then, back to Orko, our backstage editor.
Thank you, sir.
Thank you all. Please
Thank you.
Thank you all. Thanks for watching. I hope you have enjoyed this in live version and also in recorded version. If you have, do make sure to give it a like, then subscribe for more. And we give daily updates on the CME and other topics on our Telegram channel. The link is in the description below. Please do give a check. And we have a Spotify playlist. Also give it a check. All the links are given below. To get updates on every CMEs. We have Facebook. Make sure to follow that too. So with this, it's me, Mukherjee, signing off. Good night.